Okay. Um, Thank you, everybody, for joining. We have people from virtually everywhere in the world. So I'm going to say good morning, good afternoon, good evening to just about everybody on the phone. I really want to just play off first that comments that Dan just made about that community that's come together around the IPS. I'm going to start and I'm going to finish there because I just think that it's been incredible to work with people all over the world on this initiative for the International Patient Summary and to see that collaboration among different nations, among different organizations like the Joint Initiative Council brings together for it, and all of this wide partner spectrum really working to make interoperability possible. My role today, that's me down here in the picture there at a recent FHIR Connectathon where we had our IPS track. I'm John DeMore and president of More Informatics, and I'll be speaking about the structure and value of the International Patient Summary. But then I think we've got this incredible panel coming after me to really give much more detail about what's going on in different nations and also from vendor organizations about what's happening. So I'll start with a brief introduction to the International Patient Summary. Then try to answer that question, why patient summary and why now? I've been working on patient summaries with HL7 for over a decade for things, but the last 4 years have really seen some incredible progress and I'd say global collaboration around the IPS, and we're seeing just incredible momentum in the past year even. And then we'll talk a little bit about what's upcoming and what's next for the IPS as well. So in terms of our brief introduction here, Dan queued this up incredibly well for it. So what is IPS, International Patient Summary? It's a standardized set of basic information about a patient. It's those facts that are most relevant for care transitions for things. In our image on the right-hand side here, you can see 6 different sections. There are actually 16 sections that are possible as part of the International Patient Summary that are profiled out and really described in the standard itself. But then it's not limited to that. You can actually include other information as well. So it really is something that allows essentially what's called open sections. So if you have more information that you need to include for a care transition, you're able to do so. The 3 that are shown at the top on the right-hand side are medications, allergies, and intolerances and problems. Those are minimum or required portions of the IPS. So those are kind of that minimum foundation that we expect to be in every international patient summary that's exchanged for it. But then we have a whole host. All 16 sections will be shown on a future slide here, like immunizations, results, procedures, social history of patients, information on advanced directives, things about their patient story, a lot of different information that can be represented across those 16 sections. One important thing about the IPS is that it is meant to be a summary. So this is not meant to be an export of everything that you've ever collected on a patient over time for things. As we know, digital data has been piling up over the past couple of decades, and that can be a lot of information. We're not expecting all of that in the IPS. We set a minimum threshold, as I mentioned, those problems, allergies, and medication section for what we expect in an international patient summary. But we don't expect necessarily all the data that's ever been collected. Maybe a lab result from last year is relevant, but maybe something from 12 years ago isn't necessarily. We want that information to be provided in a specialty agnostic and condition independent way. So the International Patient Summary isn't just for rare diseases, isn't just for a particular metabolic or cancer, but it can be used really across those indications for things. And those words that Dan mentioned earlier on about unscheduled and cross-border care, we're going to double click on that on the next slide here, just to talk a little bit more about kind of what that means. So unscheduled care is our primary use case for the International Patient Summary. And obviously this, the scenario that comes to mind here is when you're traveling. And if you're traveling, internationally, you might want to have your medical record with you in case there's an emergency for things. And you have to interact with a new care provider who doesn't have any history on you, and frankly might not be able to access your medical records in other organizations across nations or other boundaries for things. So really empowering that continuity of care is one of the fundamental things for the IPS. Now, is the IPS only for unscheduled cross-border care? No. It can be part of care referrals and planned care transitions. It could be part of planned medical travel for things, and a whole set of other use cases, but we use that unscheduled cross-border care as our primary use case to ground the IPS. It really gives us some direction on things. And now, when you hear that word cross-border, you're probably thinking international borders for things. So obviously, when you're going from Europe to Asia, from Asia to the Americas for it, those are big borders where you're going to be crossing country borders for things. But IPS is not limited to that. Graham Grieve, who's one of the founders for FHIR, Fast Healthcare Interoperability Resources, I think has a great saying that a border starts at your front door for things. So borders can be national borders, they can be regional borders, they can be state, they can be provincial, they can be other types of local borders, or organizational borders. If you have two hospitals down the street that are using different technologies for electronic health records, that's a border. The international patient summary is applicable in all of these scenarios. So we start at a global, or what's called universal realm within HL7 of setting up the international patient summary, but then we know that different nations will pick it up and begin to use it in different ways. And we're going to hear about that from Canada, from Brazil, from a lot of different perspectives during today's presentation for it. But that word cross-border is very important when you think about the international patient summary. So I mentioned I was going to show a little bit more about the sections. So in the upper right of the slide, you can see we have document information, which is about the patient, author, attester, and custodian. But then we have our 16 sections that are across the slide there. The red ones are the ones that are required. The orange ones are really required if known or recommended sections for things like procedures, immunizations, medical devices, including implants and results on a patient. And then we have a set of optional sections as well, like advanced directives, alerts, functional status, history of past illnesses, history of pregnancy, patient story, plan of care, social history, and vital signs. So that is really what the IPS is from a content perspective. But as Dan can queued up, to make it implementable, we put it into two different standards within HL7. One is CDA. We won't speak about that too much further today. But the other one is FHIR, or Fast Healthcare Interoperability Resources. Within FHIR, you're going to have a bundle. A bundle is just a way to package together a bunch of individual resources in FHIR. And our bundle type for the international patient summary is going to be a document for things. When you have a document in FHIR, the first part of the bundle is going to be what's called the composition resource. The composition resource is really a key resource when you're pulling together any type of document, but certainly medical summaries, to be able to link all this information together. So the representation of FHIR can be both in XML or JSON, for those of you a little bit more technically capable for it. But when you dig into that composition resource, what it's going to have is elements about the document, what language is it in, when it was generated, the text of this. It's going to have information about who this is about. Generally, an international patient summary is going to be about an individual, so a single patient for things. It's going to say who authored and who custodies that information, what clinical services may have been associated with the production of this international patient summary. But then it's going to have a key thing. That key thing is the sections of the IPS. Those are those at least 3, but potentially up to 16 or more sections if you want to include things that aren't profiled within IPS. Each section of the IPS includes narrative information. This is meant to be something that's human renderable, so a clinician or another patient or caregiver could view this relatively easily, and you don't have to understand all the complexities of machine-coded information to be able to do so. But then also, if you have a system that is FHIR aware and ready to process and use this information for all those things Dan talked about earlier, like clinical decision support, maybe AI, or you just want to bring this information into your electronic health record, you're going to use those references to individual resources. So those link back. The subject links back to the patient resource in an IPS document. The author is generally going to be a practitioner or an organization. These can be automatically assembled, or these things can be human curated, or it can be a combination, any thereof. And then the sections are going to point back to the individual resources. So how many resources are you going to have in IPS? Well, we don't know until you produce one. You could have one allergy, you could have many allergies, or you could have no allergies in IPS. All those things are permissible in terms of the specification. So that's a little bit about the structure and about how IPS works for it. If you want to get more around the IPS generally, we have actually a public-facing website. I'll also give links to the specification here as we go forward, but you can bring out your phone. We'll have 2 opportunities to bring out a phone and use a QR code if you don't want to retype things in a browser. International-patient-summary.net. is a public-facing website that really gives the introduction to the IPS, speaks at length about those different standards development organizations that participate in the development and the maintenance of the IPS, and also talks about implementations across the globe. So it's a great place to go for news, and we do work through an editorial team to keep that information up to date. So you can scan that QR code, go to international-patient-summary.net. But now you say, are patient summaries new? And the answer to that is no. We didn't invent a patient summary in the past year or two. We've known that patient summaries are pretty critical for care transitions for many decades. But let's talk about, why is the international patient summary taking off now? Um, and the IPS enters into a context of document exchange that's existed in the world for many years. In the United States, we've had document exchange for well over a decade. As we had a big program to promote the adoption of electronic health records, we began to use a standard to exchange medical summaries. And that was called CCDA, or Consolidated Clinical Document Architecture. The current version of that is 2.1. It's a US realm standard. And truly, billions of medical summaries are exchanged already annually in the United States. That really predated a lot of the work that was done on the International Patient Summary. As Dan mentioned, some of that originated out of European work that was done to support European patient summaries, but then eventually went to the International Standards Organization, or ISO, and became the 27269 standard for what became the abstract or the data model for the International Patient Summary. Europe has continued to exchange European patient summaries in the CDA format for the past decade as well, so that's already active. And frankly, I'm only talking about the United States and Europe, but many places in the world were already doing medical summaries before the International Patient Summary. But what we saw is a couple things for this. There was some adoption of the clinical document architecture for exchanging medical summaries. A lot in the United States, definitely some in Europe, some places else in the world, in both Australia, Asia, and other places. But we also saw that not all places were able to take up that standard and to use it to its fullest extent. There was still a lot, and there's still a lot today, of faxing and paper and PDFs for exchanging medical care summaries. Obviously, the exchange of any information is good, and we try to make that possible. But when you want to make this information computable, so it can do all those magical things that EHRs are able to do to be able to improve care, we know we have to go beyond that. And there's this real opportunity to use FHIR, the Fast Healthcare Interoperability Resources, which is really lighting up across the world for being able to use that in documents such as the IPS. And before 2024, it wasn't really pretty prevalent for the use of what was called the FHIR clinical documents, and particularly the FHIR International Patient Summary. But we've really seen that take off, and we're going to hear from Canada today. We're going to hear from Brazil today, and I'm going to also talk about a couple other initiatives that we're really seeing proof points over the past year. Why are medical summaries important? Well, medical summaries are really just part of that whole ecosystem for interoperability. There are times at which you just need to extract just one piece of information, the conditions for a patient or the allergies of a patient. But often, the most common thing that happens is that a patient is at a new place of care, and they just need that summary. They need that background. They need the pertinent medical history for that patient to understand the context for what needs to be done next for it. So the IPS provides an international format. As I mentioned, it's a universal realm standard. So HL7 operates in many, many nations worldwide for it, but this is meant to be universal realm. It can be used in any nation worldwide for it. And it's done in a way that it uses region agnostic terminologies. For those of you well accustomed with medical data, there's a lot of different terminologies worldwide that are used to encode medical information. In the IPS, we try to do so in a way that uses global terminologies. One of those is the SNOMED. You saw that on Dan's earlier slide, the Systemized Nomenclature of Medicine, in using that worldwide. Many nations are already SNOMED affiliates, and they can use the entirety of SNOMED CT in their International Patient Summary. But SNOMED has also made available what's been called the SNOMED IPS terminology, which is a subset or a sub-ontology of SNOMED that's made available. It's a Creative Commons license and can be used anywhere worldwide. So a very powerful thing. What else around the IPS? It empowers both patient and provider mediated exchange. We'll talk about both of those really on the next slide. Dan alluded to this, which is patients being able to have the freedom to take their information with them when they travel. Almost every nation worldwide has rights for patients to be able to bring their information with them, and the IPS provides a conduit, a means to be able to do so. There's a real freedom component to that as well, but then also this can be the baseline for provider-mediated exchange when you're having a planned referral or planned care transition between a hospital and another hospital, between a specialist and a PCP. Lots of different contexts for how this can happen, and the IPS has the opportunity to support both of those. It leverages those FHIR investments that have been made worldwide for it. It allows for domestic adaptation, and we'll hear a little bit about that from Canada. We'll probably hear a little bit from Brazil around what they've done things. And we're seeing emerging support from technology vendors. So we'll hear from a couple major EHRs today around this. And it builds on just those documented benefits of interoperability. When we share medical information in a usable format, an interoperable format, we bring down the cost of care while also increasing the timeliness and the quality of that care as well. There's a great paper that was done in Canada that's specific around patient summaries and the IPS, and I will provide this link for everybody in the chat here after I get off of camera and off my presentation. So what are the proof points for the IPS in the last year? I mentioned that we've made incredible progress in terms of the IPS in the last year. In 2024, the IPS was used as part of the Hajj pilgrimage among 4 different nations: Indonesia, Oman, Malaysia, and also Saudi Arabia. And some images from the Malaysian My Sehatra app is actually shown on the right-hand side of this. This was a way that a pilgrim that was going to Mecca could bring their medical information with them. They could show that, as Dan mentioned earlier, using kind of a QR code way to share this information, and that information would be accessible if they needed to seek medical attention while on the Hajj pilgrimage. I think that this is an incredible use case for the International Patient Summary, truly empowering. Over 200,000 of them were issued last year, and literally tens of thousands of them were actually used. Canada last year launched IPS, and I won't steal their thunder. There's more coming from Atlanta to talk about what's been going on in New Brunswick, Alberta, and also elsewhere in Canada to be able to make IPS accessible within that nation, within the provinces, and make that more readily transferable as patients go across continuity of care. Brazil had a great publication in Oxford Digital Health last year about what their plans are for the IPS, and we'll hear a little bit today from Attilo about what's been going on for that. ePatient Dave presented at HIMSS 2024 about a year ago, and also went on HIMSS TV. So you can actually see that. We'll show one picture from that as well. Again, about how this really empowers the individuals, empowers the patients to bring information with you. ePatient Dave, or Dave DeBronkart, is a major patient advocate for being able to have access to your medical records and to be able to share that information where it's needed. In addition, we had major EHR vendors and also other apps that actually launched support the IPS in 2024. So what's upcoming in my last few minutes here? First, we're going to actually do some work on publishing the 2.0 update to the HL7 International Patient Summary FHIR Implementation Guide for that. That was validated in September of 2024. If you go to our what's called CI build, which I'll provide the link for here in a moment, of the implementation guide, you can see that today, and we're planning to publish that as soon as possible. I'm really working this month and next month to get that done. The 1.1 version is the last formally published version by HL7, but that was last published in November 2024, so in 2022, and we knew in 2024 it was time for an update for the IPS. We'll continue to support IPS tooling and reference implementations. So if you want to try out a tool for free, again, you can bring out your phone. You can do this on your phone. You can also just type in ips.viewer, ipsviewer.com, into your web browser, and access and play with a patient summary. See what this looks like in JSON or JavaScript object notation. We're going to continue to advance patient-mediated exchange using QR codes, and we'll hear more about that, using smart health links, and also coordinate activity among many standards development organizations. The Joint Initiative Council had a big paper that Dan mentioned last year that they would put out and are seeking feedback through listening sessions and also any feedback from the website in terms of the IPS. But they've also convened a group called the IPS Coordinating Committee, or IPSCC, which really started in 2024. I want to end by just talking about the fact that you are now part of the IPS community. I love this quote that you should never doubt that a small group of committed individuals can really change the world. In fact, it's the only thing that ever has. It's been exciting to watch IPS grow over the many years, from 2016 when there was just a few people in a room talking about this, through 2023, 2024, and really going into 2025 for things. And I welcome you to be part of that IPS community. How do you get involved? You can come to events. Obviously, you're here today on a webinar. That's a great start for it. HL7 offers both virtual and in-person events to be able to work on the IPS as part of Connectathon tracks. IHE, or Integrating the Healthcare Enterprise, also offers connectathons and plugathons that work with the IPS as well. You can attend our calls. Our calls are public, and we have weekly IPS project calls. Wednesdays, it's 9 a.m. US Eastern time. You can join us on chat.fhir.org. You don't need to pay to sign up for an account. You create a login, and you can go ahead and begin speaking with FHIR experts all across the world working on initiatives. The IPS has a stream, which you can subscribe to as part of chat.fhir.org. You can attend a working group meeting. We'll be meeting in Madrid in May for it. I'm hoping to see many of you there. And you can also comment on the specification. And here is the link for the specification, which I'll also provide in the chat in just a moment. Thank you so much for your time and attention. I know we're going to have time for questions at the end. I'm handing it next, I believe, to Alana from Canada to speak for it. But there's my contact information as well.
Thanks for watching. If you found this helpful, give us a like, subscribe, and hit the bell so you won't miss the next one.